Hello, everybody. I'm Skip Lowe, and joining me today,
Colton Storla.
all right, we're with Community Connected Health. We're honored to have you here. And speaking of being honored, I'm honored and have, with great adulation, I get to introduce our next guest, Amy Wadstrom, good friend. She has been in the trenches with me for a long time, but Amy is the president of Vivid Clear RX. So we're going to dive into some really cool topics and what's happening in healthcare related to pharmacy benefit spending. And there's a lot to unpack here today, but been dealing with the healthcare industry for 31 years of my life, and I think that I've seen it all, but every day is just a new challenge and a new hobby we get to go ahead and explore and dig through. So we're going to have some questions for you today, but we'd probably like to start off and hear a little bit about your background, but I'm going to do a little spoiler alert because, so Amy's from Newton. So everybody that's from Newton, Iowa is hopefully tuning in here. She's a Cardinal.
Everybody from Newton.
Yes.
Yeah.
Everybody.
I think you dispensed some drugs to me at the pharmacy.
Correct.
At Hy-Vee.
Absolutely.
Yeah,
I
you
was a
remember
pharmacist there. I do.
Yeah, I always wore a suit and tie. So that's where I get my...
Yeah.
He picked up prescriptions there?
Yeah.
While you were there?
Yeah.
Yeah, we'll violate my HIPAA later.
Didn't know
Yeah.
that.
I won't tell you
Yeah,
what
what
he got.
prescriptions did he get?
Can't tell.
He's editing that part. So anyway, thank you very much for that. So so with that, why don't you go ahead and let's start off just a little bit of your background, how you ended up being president of Vivid Clear RX, who, by the way, is a phenomenal pharmacy benefit manager. We'll do the selling on that later for everybody.
Perfect.
But tell us a little about your background and how you ended up where you ended up.
Yes. Well, first of all, I want to thank you both for having me here. The pleasure is truly mine. You guys have been great partners. Excited to be here and be able to talk about Vivid Clear. A little bit about myself. Obviously, I grew up in Newton, Iowa. I went to Drake University. I'm a proud Bulldog. And I have worked for Hy-Vee, Vivid Clear's parent company, my entire career. So probably about 29 years at this point. So it's been a great place to work. So how did I end up at Vivid? In 2020, Hy-Vee was like, we need to do something different with our own benefits. We had sort of an interesting lens that we'll talk about later, but they were like, we can do this ourselves. We have tons of clinicians. And they asked me to come over and be, at that time, it was chief operating officer. And I was like, absolutely no way. I want nothing to do with a PBM. Because as I had spent my entire career as a retail pharmacist, I hated the PBM industry. And they were like, but wait a minute, this is an opportunity to really do something different. And I was like, well, if we're going to do something different, then I'm on board. So came over, started to grow a team, and the rest is really just history. So
What did you hate about the PBMs?
Everything. As a retail pharmacist.
Because you probably knew about them, but you didn't know exactly what they did, maybe?
No, well, I knew what they were
sense,
supposed to do. As a retail pharmacist, if you've ever walked into a retail pharmacy, you see a lot of people with phone cords, and everybody has a phone up to their ear because they're waiting on hold with PBM.
Yes.
So that is really super annoying. Or they're yelling representative into the phone over and over again to try to get a live person to take care of the customer that's standing in front of them. And I also knew that we weren't being reimbursed correctly because at Hy-Vee, you're responsible for the profitability of your own department. Yeah. And I just knew that, they weren't paying us even at cost for a lot of the prescriptions we were dispensing. And so it's like, how long can you continue down that path? And they also just played a lot of games. Yeah. So those were the things that I knew about them, and I knew that I wasn't going to do if I ever got that opportunity, which clearly I did. So
do you feel like the patient or the person at the counter with you was also experiencing, similar sentiment that you were, or were they kind of clueless of what was happening?
At my pharmacy, we actually tried to take care of the patient. A lot of pharmacies would have just said, Mrs. Smith, here's your prescription back. It won't go through your insurance. You're going to have to call them. My theory at my pharmacies that I worked at and ran was, we're going to call the insurance for you, figure out what's going on, and get you taken care of. Because at the end of the day, we wanted to make sure the patient had their medication. If you're a patient at another pharmacy, you might go home and never fill that prescription. And really that, is a tragedy in the healthcare system to not get your prescription.
Yeah. Well, the opaqueness of the pharmacy benefit management, and admittedly to the listening audience and people that are watching us on TV or wherever they're streaming, as a health insurance consultant, it was one of those do not enter portions of the health plan, because for years and years we focused on the deductible and the coinsurance, the major medical, the provider level. And all of a sudden, out of nowhere comes these high cost drugs. And I just felt like I was so behind in the evolution, and realized that, a lot of people on my side of the coin, so to speak, were behind it. And just digging into the morass, when we all suspected something was just amiss here, right? And as healthcare costs ended up skyrocketing, we were starting to look at these really high cost specialty drugs. And I think the stat out there is that 2% of the population now is 50% of the overall spend for prescription drugs related to, your Storlas or your Enbrels, the real high cost medications. And so, there was a lot to unpack. And so we were on the other end of the phone with our clients and patients that are saying, why am I not able to get this medication? It was dispensed as written, and you told me this was going to be covered. And we also saw the dismantling of our rural health care system, as well as our pharmacies out there too. So it became more labor intensive to take care of our I wouldn't say patients, but our clients. And you can't beat a good pharmacist. I mean, they are just such a critical part of the health supply chain, as well as the ecosystem. And so you've been on really all sides of this, and now you have to deal with brokers, consultants like us. How's that part going, by the way?
That's been interesting. When we first became a company and they said, go out and sell these services to other people. Yeah. And it's like, you have to meet with brokers. I'm like, what's a broker? Yeah. What do they do? And so a lot of that was, meeting with people like yourselves and really educating ourselves as to your role in healthcare. And we've really grown to value that relationship of the broker consultant with the employer group. It's really important.
Yeah. Aren't you nice? Yeah. Wow. Thank you.
It truly is.
Well, I feel like you probably also had to, because with pharmacy benefit managers, I mean, I just was reading a post on LinkedIn, and I can't remember what they were talking about, but it kind of brought back a prospect meeting that I was in with a self-funded employer, and we started throwing out PBM, pharmacy benefit manager, and they're like, what is this PBM you talk about? And it's like, wait, you don't know what a PBM is?
Yeah. Exactly.
So maybe we need to define that first for people that don't know what a PBM is, or a pharmacy benefit manager, and what your role and responsibility is in the health plan.
Welcome to the land of acronyms, right? Yeah. HMOs, PPOs,
yes,
right?
Exactly.
HSAs, FSAs. So yes, let's slow her down.
So I think, first of all, you have to look at where the PBM industry is today and where it really should be, because what PBMs, we're going to put them into two buckets, right? The PBMs of the past and the new PBMs that are transparent pass-through like we are. I think the PBM world gets thrown into one bucket, and not everybody is created the same. So my PBM, VividClear RX, is actually all of our executive team is pharmacists. And I think that's important, because truly being a pharmacy benefit manager, you should be a pharmacist with that knowledge and making good, solid clinical decisions while also being fiscally responsible. And so I think, putting people, keeping in mind that there is a person behind that prescription, behind that number, is really important. And that's why I became a pharmacist, was to help people become healthier and live a long, healthy lifestyle. And so really keeping those in line, along with fiduciary responsibility and, costs, are very important for clients, for them to be able to offer a good, healthy benefit for their employees. And I think, to truly manage pharmacy benefits is not chasing rebates. It's not, trying to figure out how much money you can get from big pharma. It's literally figuring out the most cost-effective way to treat what's wrong with those members, and doing follow-up to making sure that they're doing okay, and really doing the extra. But prior authorization and getting the right drug for the right patient at the right time in the right order is also very important. And that, at the end of the day, is really what we're doing. We're racing to lowest net cost, and with the patient's health at the forefront of every decision that we make.
Yeah, well, I'll sum it up and say your goal is to meet business and science somewhere
Absolutely.
in the middle. And that's where we get off kilter a lot. Obviously, there's the profitability. And so for the listening and viewers, the pharmacy benefit supply chain is you have the manufacturer, you might have a group purchasing organization, you have the rebate aggregator, and then you get down to the pharmacy benefit manager. And there's been a lot of people talking about pharmacy benefit managers, the middleman, as they're referred to. Whereas just a few years ago, our politicians would say, oh, these evil empire manufacturers. And somewhere along the way, some education was obtained by our politicians, and we started talking about pharmacy benefit managers. And so it's almost become, dare I say, a vulgarity to say PBM now, because now they've all been put in this bucket of like, oh, the middleman that are really ripping us off now. And so that's what we're trying to do, is just slow the ride down and let people know that, yes, pharmacy benefit manager might be a title here, but what are they doing? Where business meets science. And that's really the key for us too, because we see the financial barriers where people are getting medications at the pharmacy, they're paying $500 and they just turn around and walk out.
Yeah, exactly. And having been a pharmacist at that counter who has to tell the patient, hey, this is going to be $500, I knew before I even walked up there that patient wasn't going to be able to afford it. So we are working in the background in the retail pharmacy world, trying to figure out, is there something else that they could be on that would be less expensive? Is there a copay assistance card that can help them? Because I know that when I go up there, they're just going to...
It's not just a transaction.
Correct. It's a person.
You're problem solving for someone.
And so, as a PBM, when you take that, sort of background and where you come from and bring that in, that is a difference maker, because I think for so long it's just been big business and the people don't matter.
Well, it just crushes you because, in Skip and I's position where we are meeting with clients and we're going to open enrollment meetings and talking to patients. And, we kind of see that side of it too, because I think sometimes employers don't think twice about raising deductibles or changing their copays on their medications, not paying attention to what their formulary says. And, if someone doesn't dispense that medication, well, now they might be going to GoodRx or they're not taking the medication, God forbid. But then I always try and level set with employers. It's like, you're paying all this money to your insurance carrier and your pharmacy benefit manager is not even, adequate enough for your people. So they're trying to find these other avenues. So why not work with a right partner where we can remove some of those financial barriers to care?
Well, and the thing is that we've really kind of taken to heart is all groups. As we've continued to grow, we've noticed that all groups are not created equal. So if you have employer group A and employer group B, employer group A may have, their struggles may be diabetes and whatever over here, and over here, mental health may be a big concern. So when you're looking at a formulary and you're looking at their spend, there's different tweaks that you can make. But if you're just running to get the most rebates or the biggest spread or whatever that looks like, and you're not taking into account a strategy for each individual group, then you're just contributing to the problem.
Yeah. Well, maybe we should dive into that a little bit.
Sure.
For the PBMs that aren't doing things in the right manner, what are some of the things that are happening that maybe employers, purchasers of healthcare, the CEOs, HRs, those folks, what are some of the things that are happening with the PBMs that aren't the right things that are happening?
Yeah. So I will digress a little bit back to why we at Hy-Vee created our own PBM. We had a very interesting lens. We had 300 retail pharmacies. We had a specialty pharmacy, and we had, 90,000 employees. And so we could see, because our patients would use our pharmacy and then our benefit plan would get charged something. And we could see that what our pharmacies were being paid and what our benefit benefit plan was being charged were two completely different numbers. And so, you can do simple math on that to figure out that there's a lot of dollars that are going somewhere. And it certainly wasn't back into the employer's pocket or, the member's pocket. And so same way with specialty, like we could see that that was happening there, and that's called spread pricing. And that is something that we do not do. And, there's 100 different ways that you can pick money here and there, and charge different fees and all sorts of things. We decided that, we were going to operate just on a PM, so a per member per month fee. That's what we do. We charge so much per member. That's it. And the reason we did that was because we wanted to be sort of a watchdog in a watchdog setting, if you will. So we could watch what was going on. We wanted to drive adherence, but we didn't want to be rewarded for every prescription that was sent through the system. Because if you charge per claim, you can be incentivized to push, prescriptions through the system. We just didn't want to do that. So we simply charge a per member per month. Now, there's no big money bag sitting around at VividClear because you can do math. You're not going to make billions, but we make a fair fee for the services that we provide our members, and we take excellent care of them. And we're really proud of that model.
Well, you get economies of scale, and you're here to build a clock, not tell time, right? Because, the short gains that you see in some of these contracts is utterly amazing. And there's also, Colton and I have spent some time in this fun space that you're in. We're trying our best, but we've identified 40 to 50 ways in which there's hidden costs in these contracts. Mail order markup, right? They'll do a switching fee, right? Repackaging fee. Humalog was a perfect example. We did the analysis where it was the cost of the drug being charged to plan was $640 when it was the actual cost of the drug was like $220. And so there's an enormous amount of spread out there. But the formulary side is one thing that has always just bewildered me. You've got committees that decide on the formularies each and every year, and they change sometimes every 6 months. But nothing irks me more when a drug that has a high effective rate efficacy for that patient is suddenly taken off the formulary for a higher cost brand medication, and you see that all the time as well. It's been more than an intriguing dive into just the details that you have to look at, and that's why we like working with transparent pharmacy benefit managers.
I remember, even like the first year or two in the business, and one of our colleagues, Scott Wilkins, he's like, if you really want to be successful in this big business, figure out the pharmacy side of things. And then, you and I got linked up, and I don't even know how it happened, but I was like, hey, there's this, certified pharmacy benefit specialist designation.
I think that was shortly after I met you guys, and I was like, these guys are really all in.
And it was like an 8-week course. And
evangelist.
It was not easy. It was virtual during COVID. And that was a huge eye-opener because, Skip and I knew games were being played, but how are the games being played and how do you identify them? And so we had a great instructor to teach us some of those things, and it was not easy. There was other pharmacists in the class that were trying to learn. So it was.
Well, when you do go to pharmacy school, they don't. I mean, you do take like some business class, but like you aren't a business expert. You're not a contract reader. You go to school to learn clinical skills. And so you just throw these pharmacists in a pharmacy and expect them to be successful business owners. And that's a hard gig.
Yeah.
So.
Well, it's a reminder, we deal with all kinds of organizations, whether they're construction contractors or hospitals, or if they're, colleges. I mean, I go all the way down the line, right? And at every single level, brain scientists down, they just don't know this stuff. I mean, the vernacular, they're just so spun out of control so quickly. And so I will do a shout out to Tyrone Squires.
Taught us a lot.
Yeah, passionate.
And it's all in the contract.
Yeah, it's all in the contract.
It's just ingrained in the brain.
Yeah. So when all during this period of time, we met your colleague, Justin Manning, who's just like you, a best buddy. Anyway, he and I got talking. I said, well, I'm just going to, can I have a copy of your contract? Because that's always the question. That's red flag number one, as Colton would say.
Yeah.
They won't give you access to the contract.
Come out of the woodwork. Hey, can I have a copy of your contract? Sure, no problem. Give me your email address. I'm like, okay. And I'm like, we went through it and I said, this is what, we didn't have to change much. We just said, I think it was like terms.
Sure.
Like, do we have to really sign this for 3 years? Oh, no, you can, you know.
And, actually we don't charge a fee like to exit our contract. So I have felt strongly since the very beginning, if you are our client and we are not doing our job or you're not seeing the value in what we're doing, you should be able to leave without A, paying us a fee to leave, and B, I'm not going to keep your rebates when you leave because those are yours all the time.
Yeah.
And the other thing is that, when we started our PBM, our CFO at the time took this big binder out of his desk and he sat it down and he said, do you know what this is? And I said, I have no idea. I said, I hope I don't have to read it. He's like, no, you don't have to read it because this is our PBM contract right now. And it was literally like 285 pages.
Wow.
And so I thought to myself in that moment, like, we are going to have a contract that people can read and understand. And there's not an asterisk that changes 20 pages back.
Yeah.
So our contract is less than 80 pages, which is still entirely too long in my opinion, but you have to have certain things in there.
Well, you do, but the fact that you had a pharmacy benefit contract to access
Yeah.
is big. That thing's probably worth $1 million on eBay, by the way, because that's the other. Well, the other thing,
I might look into that actually.
Thing. Come on.
How many times have we asked our employers to see if they get a contract from their big, large insurance partners? And you know what the answer is? It's proprietary.
It's proprietary.
Well, you're self-funded. It's like there's fiduciary. I can get into the details.
Well, maybe that's
in
a
the
good
weeds.
segue into, carved-in arrangements versus carved-out arrangements.
You're the expert.
Maybe Amy's the expert here, but it's just, I think, a lot of employers are ingrained that, I work with some big insurance carrier and they give me all the services, the TPA, the insurance, the pharmacy, the telemedicine, and I just buy it off the shelf and I get what I get.
Yep.
And some employers don't understand that, like, hey, they make it easy for you, but they also make it easy for you so they can maximize profitability and, hide these contract terms away from you, because we have asked some carriers for the contract and they do say this is proprietary or we don't give access to that information. So yes, red flag.
Yep.
Well, and the thing is, if they have everything and it's all bundled into one, it's really hard to chase the dollar or to follow it, Yeah. So when you start to piece out, and you don't have to piece out everything, but if you move the pharmacy benefits to a carve-out PBM like Viviclear or some of our competitors, you can easily identify trends. You can easily identify where your dollars are going. And you can also easily identify if you're on the PBM side, it gives you access. We give you the keys to our castle.
Right.
So you get access to our system 24/7. You can look at anything. So we're not hiding anything. It's easy to operate. And we're able to make proactive decisions with you as brokers and consultants, and also with the employer in the room. Like, hey, we see this as a potential for you. These are solutions we have. What do you think about that? How do you feel? Do you think your employees are going to jump on board with this, or is this going to be a hard transition?
Wait, you mean you don't just set it and forget it and then let healthcare happen?
Definitely not. It's not our style.
Well, and not only that, the other key thing is you mentioned, yes, you do give us the keys to the castle. And there are other, transparent PBMs out there that we really like. But the other key thing, using the word key, is audit rights.
Absolutely.
I mean, that's the thing you really need to look at. You look at your definitions, and then you look at your terminations, and then you look at the Schedule A. But audit rights. If you're a larger employer, you say we want to audit our claims. They say, we're going to charge you for it, or they're going to say we'll bring in our arbitrators. Right. This is not a union negotiation.
Correct.
And I don't want to get too far in the weeds because I always do this on these podcasts, but I think it's important for us to recognize that we're not talking about the Boeings or the Caterpillars or the Buku companies that are out there. We're talking about the solutions that we're doing together in Iowa and across the Midwest, and really you're doing across the country. We have these solutions that are available. We didn't have 5 years ago where we can put these solutions in place for smaller employers, companies that are, 10 lives, 10 employees, 20, so we're not talking, above and beyond, 5,000 life contracts. And I think that's really imperative here. That's the other thing that was really attractive for us about what we're doing with your organization is like, yeah, we can plug into a level funded plan. So we're able to create our own solution stack.
Mm-hmm. Well, and I think the question that always gets asked to us is, what size of group are you like really good at? It's like, it doesn't matter.
No.
We are good. We, and a member of the Vivid Clear family, as we refer to members once they join us, the 5 life group is just as important as the 50,000 life group.
Yeah.
We take excellent care of everyone.
Yeah. From my point of view, it's just like, what's the average employer across the U.S.? They are small employers and they need good pharmacy solutions, just like the big buco companies, because again, it goes back to what we talked about. We need to get people access to their medications at a fair and reasonable cost.
Mm-hmm.
Yeah. That might be a good segue into, not only do we need to have good pharmacy solutions, but we also have to have good access to pharmacists. And so Iowa recently passed a legislation bill called Senate File 383.
Yes,
have you ever heard of it? Oh, you have?
I have.
Oh, yes. Wow. Okay. This is good. I don't have
Vaguely.
I always wanted to educate the pharmacist, but next time maybe. But yeah, so this is, I think it's a wonderful law because, again, as I said earlier, I've watched the slow dismantling of our pharmacy networks across Iowa. I've been traveling quite a bit in sales, and I remember saying, "Oh, that used to be the movie theater, or that used to be the factory, and that used to be the doctor's office."
Yes, I do know.
You grew up in Newton.
I did grow up in Newton, and I actually worked at an independent pharmacy called Nolan Drug.
Oh yeah,
with the best pharmacist, Henry Van Elson.
I know, know the name.
He just recently passed away, but he was an amazing pharmacist, and he was the cornerstone of the Newton community.
Yeah.
And it was a great place to work. And it was, this is going to show my age, but I worked in the independent pharmacy before computers. So Henry would actually type the label on a typewriter.
See, bud.
And we had to keep the members' history on a card, so you'd have to handwrite it, and then to submit it to the insurance, you would have to type it into this little credit card box.
Yep.
All of the information. So yeah, I'm
You've probably seen the drug prices evolve since then too.
Absolutely.
Yeah. So you're bringing that passion.
Yes.
Right to it.
And independent pharmacy is truly. For some of those, in some areas where independent pharmacies are thriving, really the pharmacist is the access to the healthcare system. There isn't a doctor, they don't have a hospital in their community. And so really PBM reform is necessary to be able to keep those rural independent pharmacies open and have members in those communities have access to healthcare. Mm-hmm. And so that was really, I think, the driving force behind the PBM reform movement in Iowa in specific.
Which it's not just happening in Iowa. It's
correct.
Happening in other states.
Yeah.
Everywhere else. And and there's been, how it is when a law passes and everyone takes their position and it just drives you crazy. And, this one in particular, there's just so much misinformation about what this meant. And there's been, just some drama.
Yeah, Vivid Clear has really tried to, we came to market as a reformed PBM, essentially, if you will. So we most of our practices, well, all of our practices really conformed with the law.
Yeah.
To be frank. So we didn't really have to change a lot of things to comply with the law. The thing that we ran into was the misconception in the pricing changes with the new NADAC plus 1068 versus an AWP model. And so a lot of the numbers that were out there prior to going live were that every prescription was going to increase by 1068. And that just truly isn't the math behind it. So if you look at NADAC as a measuring stick, NADAC pricing is typically lower. It's a lower cost, and that's why you add the dispensing fee onto it. So for our clients, that we did some predicting for. We predicted a negligible increase or in some cases a decrease depending on what their mix of drugs were. And now we've had a few months under our belt, and the increase has actually been less than we initially predicted, but it certainly wasn't all of your prescription total times 1068. That just...
Yeah, so I'm gonna give us the coloring book version of this because this is some of the vernacular I learned in pharmacy school.
Okay.
But you have average wholesale price, right? And then you have maximum allowable charge. And those are price lists, kind of like when you go buy a car, you're going to get it's negotiable, right? NADAC is National Acquisition Drug Cost. That is set forth by the Centers of Medicare,
Correct.
CMS. Okay. So to me, that's kind of like the gold standard. And so what that means essentially is the smaller pharmacies, the independent pharmacies, were going to get the NADAC pricing, which was more fair for them to cover their ingredient costs, because that's been the source of them, the bane of their existence, why they closed down, because you hear it on the news all the time. I can't keep my pharmacy open because I'm not getting I'm not able to cover my cost for that medication, right? So, and that's the truth. And so this NADAC pricing that goes into effect, and it has, supposed to, is actually helping those smaller pharmacies because they're actually being able to cover their ingredient costs. And then the 1068 is going to also help them, again, compete with the AWP MAC pricing, which is your big chain pharmacies, right? Your Caremark CVSs and your Walgreens and those folks that, I think last year CVS had $120 billion with a B. And they're situs in Bermuda, not Bermuda, Mexico. Okay, Bermuda, New Mexico, not Missouri, but Bermuda. And so, it's a law that has been long overdue in our state, and it's also going to open up the door to more transparency on the rebates.
Absolutely, and we have clients in other states that have passed PBM reform, and we're seeing exactly what's happening in Iowa, which is, pharmacies are getting reimbursed fairly, and, there may be a small negligible, and I say negligible because if you have one patient go on and a specialty drug, it's going to increase your cost more than this PBM reform is going to increase.
Yeah, this is not the vivid law. Let's make that clear, because we have other PBMs that we're dealing with, and we have done the measuring on that, the analytics, and it's a wash.
Correct.
And we're helping our small town pharmacies.
Correct.
Ladies
and
gentlemen.
You look at like an independent pharmacy, and even Hy-Vee for that matter, we have 300 retail pharmacies, and you compare them to a Walgreens or a CVS, it's really about the buying power, even a Walmart. So they have nationwide chains that have thousands of pharmacies, and then you have independents that are in a buying group with, maybe 50 other independent pharmacies, and then you have a Hy-Vee that has 300 pharmacies in the nation. And so, it comes down to buying power of the drugs. And so in order to stay in business and even break even, there has to be something that changes as far as reimbursement goes. And, the fact is that the PBMs, bully independent pharmacies into signing really bad contracts, or else they don't get access to those people that are in their communities that they've taken care of for 25 years.
Right. Well, they have what they call movable MAC lists too. So they're I don't know, help me out, you're the expert, but every Thursday they update their MAC lists.
It's updated often.
Yeah.
Yes.
And so what happens is we have this thing called a clawback. Like, we overpaid you last month, so your next check, we're going to go ahead and take the money back that you were supposed to pay us, even though you didn't pay us for it, although we charged you for it. We're actually going to take it out of the money that you're supposed to pay us.
Correct.
Slow
Something
that
like
one
that.
Down.
Yeah.
You always are speeding me up on the podcast, so touche.
You're right.
Thanks, bud. Okay. Well, that's kind of a hot topic.
It was.
Yeah.
I am very thrilled that it passed, and obviously there's some litigation going on right now, and it will be ongoing. And I think that's happened in other states as well, and that's okay.
Yeah.
Well, I mean, if nothing else, hopefully that employers are seeing that in the media, and they're like, okay, well, maybe we should look into this pharmacy thing.
Exactly.
Because they're seeing it on their claims reports if they get access to them.
Yes.
That their pharmacy spend is skyrocketing right now, and
if you don't have a good partner that's saying, "Hey, we recognize that it's going up. These are some ideas of ways that we can at least like just keep it level."
Yeah.
Well, let's get into some of those.
I love the reformed PBM though, by the way, because we were going to actually call this the Born Again Broker Show, but he talked me up. But okay,
well,
Born Again Brokers with the reformed PBM. I don't know.
Well, I mean, community connected health and local pharmacies.
Yeah,
it's all connected.
Yeah, exactly.
It's like, how can we continue to just focus on healthcare in our communities and make sure that it's not disconnecting, it's connecting people, because they're going to get the drugs that they need, the care that they need, what's the result of that? Less emergency room visits, probably less hospitalizations, probably. So
less absenteeism.
Yeah. We're increasing adherence, all those good things.
Lower your workers' comp claims because the hip bone's connected to the medication bone is connected to the I tripped over the front door walking into work bone because I couldn't afford it. So I'm just going to get sick at work.
Yeah.
Yeah. All good.
How about biosimilars and specialty drugs? So you talk about, some of the trends. I mean, that's where the high cost claimants are coming from. And, it's so easy for us to sit in front of a client and talk about their pharmacy spend, and in their minds they automatically think, well, we need to get more people on generics, and that's going to help our costs. But it's like, that's not where the expenses are. It is the high cost brand specialty medications. And so what are some of the things that employers should be thinking about?
So if you're with a PBM that says we have a biosimilar strategy, and they might not tell you this, but you should ask, are you part of the manufacturing process, or do you own part of the biosimilar product? Because this
Are you implying that PBMs now create their own biosimilars?
Correct. Whoa. And so they can set
Why would they do that?
They can set that price wherever they want to. Now you're double dipping again. There you go.
Goodness.
It goes back to that vertical integration.
It does. Yeah. It does. And, some vertical integration is healthy.
Yeah.
You can use it to drive some value. But, in the biosimilar space, for instance, when Storla had a biosimilar come out, VividClear, we knew the price of the biosimilar was going to be significantly less. And so we were an early adopter. So you have to figure out when that tipping point is, like the rebate and the cost of the drug. I mean, it's just doing the math to get to lowest net cost.
Yep.
But we were an early adopter of Storla, and we have actually 100% of all of our Storla users that are using a biosimilar. And by biosimilar, I actually mean the lowest net cost biosimilar, and not something that's manufactured by a PBM so that they can take some money off the top. We obviously don't manufacture. We own nothing in manufacturing. We just partner with like Mark Cuban Cost Plus. He has access to some of those biosimilars, and it's a very, very low cost. And so we're able to help our patients, educate our patients about that program and get them over there. And then they're able to reap those rewards for low cost, as well as the employer group. So.
Yeah, we'll take a little off ramp on that because that's a really important thing. Mark Cuban, I was going to ask you, what do you think about what he's doing? You've already answered that question, but there's this discount card called GoodRx, and many people use that instead of their insurance. As Colton would say, it's like, well, why do I even buy insurance when I'm using GoodRx? I walk with the pharmacy window, it's $500. You freak out, and they say, well, we got this little card here, and they run it through, and it's like $200. Well, what are you going to do as a consumer at that point? Take your $200. However, the unknown part of that to most people is that $200 that you use for GoodRx doesn't count towards your accumulators on your deductible and out of pocket, which is important with everyone that's got a high deductible. Whereas your integration with Mark Cuban, when you direct people to them, the answer is yes, you do count whatever discount you get from them to the lowest net cost, so that people are getting their credit on their deductibles and their out-of-pocket maximums, which is the integrity part of what you do. That's a huge thing, because at the end of the year, we've had people call us up and say, hey, I use this GoodRx card all year long. I hit my deductible where's my credit for this? I'm like, sorry, but you guys are doing that. That's a big thing.
Yeah, we are. And, the Mark Cuban Cost Plus Drug Company has been a great partner for us. And he, he just came to healthcare because he was like, this is really, really, I won't use the word he uses.
Used a couple cuss words.
Yes, he does. But
I'm here to
yes,
things up.
and that is really what he's doing. But
and we
really
need more Mark Cubans doing this because employers are listening.
We're
Yes.
cable friendly. Let
Absolutely.
it fly.
And it's like he looks at it from a logical person's perspective and says, this is just all wrong. Like everything is wrong.
Yeah.
So what he's really done is he's bought generic drugs or biosimilars at a low cost, and he adds whatever his margin is. I think it's 15%.
15%. Yeah.
And that's the cost for the prescription.
Yeah.
And it's only going to go down. And so, he's trying to figure out ways to, start a health plan where things look different there. And so I'm super excited to see that. And, just he's just looking at things from a different lens, and he has no.
He's a businessman.
Absolutely, and he has no loyalty to anyone, and no one's in his back pocket, and so he's able to make decisions that others can't do because they're conflicted.
Well, I mean, he saw it in his own company. I was at a TPAC conference, and we were able to Zoom with him while he was flying somewhere for about an hour, and he was telling his story about one of his companies where he was looking at his pharmacy spend and had someone come in and evaluate it. And he's like, are you kidding me? And found an alternative solution, fired his broker, and now he's on this, I don't know.
I love it.
Yeah, he's on a tear.
I love it.
Yeah, well,
and people are listening. I mean, things are,
it's not easy.
Not to get political, but, Donald Trump now has Trump RX where, he's got 6 drugs that you can buy from
Mark
pharma.
Cuban likes it.
He does like it, actually, because it's a very good compliment to him.
Yeah.
So
it is.
Because he did it first.
Things are on the move, and that's just the thing. I think I said 20 years ago, I keep dating myself, but I kept on saying, this is unsustainable. I saw family insurance premiums, I think it was in 1997, which is almost 30 years ago, go to $1,000.
Colton, were you born then? No.
Yeah.
Okay.
Yeah,
97? Yeah, he was. I think he was just out of diapers at that point. So I think he was still giving me advice back then.
Okay,
gotcha. Anyway, but I remember seeing premiums on renewals that go to $1,000, and now I'm seeing them where they're $3,000, and I keep on saying the same thing. This is unsustainable, and I'm just looking at this as what is the end game of this? And I think there's such a movement out there. And I think it was in the last podcast I mentioned, I said, I feel like we're the pioneers where we're out, crossing the rivers and going up the mountains, and grizzly bears are chasing us. And
it's definitely not easy to be doing something different.
Yeah. No.
I would say if you're an employer group or a person that's in charge of purchasing benefits, and your broker consultant is bringing you the same thing year after year, the same solutions, and not looking at anything different, or not asking you, hey, we should look at your pharmacy spend at carving it out. I think that's irresponsible. There's a lot of really good solutions. We have a lot of really good partners in the space that are doing a lot of really different things. And so if it was easy, everyone would be doing it.
Yeah.
It's not. It's hard. You have to trust in your partners, in your broker consultant as an employer, that they're going to do the right thing and take care of you. And that trust is hard to come by because of the stigma in the industry.
Yeah.
So,
well, it was real easy to launch a rocket to the moon, right?
Yeah.
It's real easy to survive in life and go to work every day. I mean, easy is just, it's part of our life that doesn't exist.
Mm-hmm.
And,
yeah, I mean, at this point, it's such a big expense for employers.
Mm-hmm.
And so, employers need to start asking questions. And it's not because they should, it's now they have to.
They absolutely have to.
They now have a fiduciary responsibility over their health plan. Mm-hmm. And we're seeing the lawsuits happening.
Absolutely.
All across the country, that employers are being sued by their employees because of their pharmacy benefit programs. So it's not that you should do these or it's hard. Yeah, it's hard,
you have to.
But it's very rewarding at the same
is.
time, because now you're taking, one of the highest expenses in your company, and now you're eliminating, 20, 30, 40, sometimes
absolutely.
50% of that cost.
Well, and we've had, groups that we've worked with. So we'll go in year one and, make some changes. And then year two, actually the employees get a reduction in their premiums because we've saved the company so much money, which is super rewarding to us. And then when we go back the next year for the open enrollment meetings, they're always so thankful. And I think if you can even keep their premiums the same in today's landscape, like, you're winning. And so that's been really rewarding for me, because I feel like we've been able to make a difference, and as a pharmacist, that's exactly what I want to do.
Yeah, I think that's really important, because, and that's, again, going back another podcast, it's like, finally to see the other side of that coin, where, you've been trying to manage just the insurance model itself, maybe going to a partial self-funding or a level funded plan. And hopefully at the end of the year, you got a check in the mail, maybe a wellness plan, and you're hoping to make differences in people's lives. And wellness plans are all good and well, but, unless you have a big company, you just don't see the credibility there. But when you're talking to employees at the employee meetings, and they come up to you and say, wow, that really did work, and I did pay $0 for my medication or $0 for my surgery. Those are just life-changing events that I've never in my career had that experience until the last couple of years. And I think it goes back to the folks that are really working hard on trying to reimagining healthcare. And it's just been an honor to have you here today. But the one thing that I would say rings true with the people that I'm working with now in this evolving world is that they're building on the values that they brought from the very beginning. You started in a small pharmacy, you started in a small town, and you're passionate about finding the solutions to, restore the American dream, or to make this, a better experience for people and get people well, because if you don't have your health, you don't have anything.
That's 100% correct.
It's everything. It just is. So,
well, and that's the kind of the fun part about what we do, is finding partners like Vivid Clear and you and Justin and everybody else, because you've seen that other side and you're trying to make it better. And I feel like there are thousands of stories like that in our industry, not even just on the pharmacy side of things, but someone that saw the negativity or disconnect in healthcare, and they're like, okay, this needs to be solved. And they're just reimagining a better way. And they're making money along the way, but they're also, having that patient or the member having a better experience.
I would be remiss if I didn't give a shout out to my operations team. So Angie Danielson on my team leads that portion of our business, and she is obsessed with service, which service, I feel like, certainly in the PBM industry, but in healthcare and actually in the entire world, is a lost art. I mean, it just really
Look at the net promoter score of
in the
companies
PBM
in
industry
healthcare,
right now,
and
it's -6, which is -100 to a +100. Ours is actually a 95. So that tells me we're doing something right. But we view ourselves, and Angie's really focused on this, as educators. So most people don't understand their healthcare, and they just get super frustrated. And it's such an important part to Skip's point. If you don't have your health, you have nothing. She's very focused on educating. And so our care center team, who actually answers the phone and takes care of our people, our members, they are focused on educating them. So when they call in, or we make outbound calls to tell them about a prior authorization, it's really about educating that member and making them feel like they understand what's going on with their healthcare. And so that's also been super rewarding too, which is really what a pharmacy benefit manager should do.
Yeah. And we can piggyback off of that and give our service team a shout out too, because they're sometimes fielding these questions first with frustration. And, if you're sick or not feeling well and you can't get your prescription, they are up in arms about it. And so being able to help them through that and educate them, because people don't understand their insurance, their benefits, the pharmacy, and how it all works. And the more we can educate them, the more they understand. better consumers they can be, but even when we need to escalate things to your team, things get taken care of. And
well, I tell my care center, like, I'm sorry, guys, you picked a really hard job.
Yeah.
Like, nobody is going to call us to thank us for their $25 copay or whatever. They're calling us because they're confused. They can't get their drug or something is going awry. Like, they're not calling to thank us.
Opportunity.
So, like, that's an opportunity for us to change their day, potentially their life. I mean, legitimately.
Oh, yeah.
And just to do something different. And so we encourage our people to take the extra step and ask them how their day is and tell them you're going to make their day better. It's important.
I'm happy to pitch your customer service. It's second to none. And I like the fact, I called it customer service, didn't I? It's the care team, care
It's
service.
okay.
Yeah.
They do provide excellent customer service. So.
It's care. And,
it is care.
It's an emotional transaction. You get sick, you want to get fixed right now, and it's amazing all the different variables that run into play. It's like, well, actually, you're using your old ID card.
Yeah, I mean, usually it's something very small.
Sorry, wrong birthday.
Yes,
we got
exactly.
Okay. It's okay.
Yes.
Your name was
Keyed in the
misspelled.
number wrong.
Yes.
Yeah,
but
or your doctor didn't call you back.
Yeah, and we just look at it as an opportunity to become connected to our members, and really our care center. Some organizations look at that as an entry level position. We actually do not. Those people are really the first and sometimes the only impression of our company, and so. They're very important to us, and we spend a lot of time with that team talking about strategies to do things different, or if we have something that maybe didn't go the way that we wanted it to, how do we want it to go next time? But really, they are the key to our success, and I could not be more proud of that team.
Well, I don't know what you did in your application or hiring process, but everybody that I talked to is not only nice, but they got great memories.
Well,
oh yeah, I remember talking to them on such and such. I mean, it's you guys you document everything, which is great.
We do.
Yeah.
And like we have a sense of urgency, which is something actually coming from retail, everything was urgent.
Yeah.
And so then coming to the PBM industry, I was like, there is no urgency here.
Well, maybe we can tell a story about the CEO that we had at one of our groups that
You can tell that story.
Yeah, you probably tell it better.
I didn't know who it was.
Yeah. No, go for it.
Well, we had a member. I can't even remember what the issue was, but this member had an issue on the weekend, and they had called in, and I actually saw the email, and so I just said, I'll take this one. And so I called the member back and helped him figure out whatever it was that he needed, and it was just a small issue. Turns out it was the CEO. I had no idea. I mean, it could have been anyone, but he was like, wow. But
does everybody get this customer service?
And I was like, I had no idea. But yes, everybody does.
Yeah. And it was after hours, and he says, hey, just because I own the place, is this like, does everyone get this? And it was, yeah.
No,
customer service doesn't go out of style, right?
It doesn't.
Good service never goes out of style.
That is good. I might steal that.
I got a few for you. Okay.
Well, maybe we can wrap things here. Maybe some action steps for either, consumers or CEOs, CFOs, HR leaders. What should they be doing? What are next steps?
I mean, if I were an employer, which I am, but if I was an HR person or somebody that was a decision maker in the benefits area, ask questions. Ask what you can do different. Ask what partners are available for you to partner with. If your pharmacy is still bundled in, at least unbundle your pharmacy benefits. It is a difference maker. And then find a good strategic partner that you want to stay with and is going to show you value. So my goal is not to get them to sign a 3-year contract. I'll do a year by year. But I want to have a long-standing relationship with that group. And it's no different than having a pharmacist-patient relationship. I mean, that should be a long-term relationship. And so that's what we're striving for. So find a partner that you can stick with, because it's really important, and that's innovative and doing, different things. And then look at your contract, ask for the contract if they'll give it to you, and ask some questions. But really just find somebody that sees things differently than the status quo.
Well, even on the innovation side of things, and maybe we can wrap it with this, what do you see happening in the pharmacy space, futuristically, or what are you guys actively doing to continue to evolve and innovate for your own clients? Because you're not just now a PBM and you continue business. Sure. It's how are we continuing to get better?
So I think, something that is going to continue to be a focus for VividClear in particular is service, just because I think service determines the success or failure of your benefit plan in your employees' eyes.
Agreed.
And so it's a complete differentiator. So service is very important. I think having a strong biosimilar strategy and then having a strategy based off of what the group struggles are. And have that be very group specific. And so not treating everyone like a one size fits all. So figuring out how you can collaborate with the group and make a difference in their spend. Having good, solid clinical programs. GLPs, we didn't touch on that, thank God, because I'm tired of talking about them.
I was like, do you guys really want to talk about that? Like there was a webinar even this week about GLP-1s.
But if you are going to cover GLPs, for weight loss, having a wraparound, product that goes with that, we're perfectly positioned for that because we have access to 100 plus dietitians from Hy-Vee, which do make a difference with those drugs. Mm-hmm. I mean, you have to have some companion program with them. So I just think having different thoughts and different conversations and really digging into the details is important.
Well, and how do you dig into the details? It's getting access to the data. And the data tells a perfect story about, what your population is struggling with. Yep. I mean, we're seeing mental health claims climbing, which there's a lot of prescription drugs tied to that. Mm-hmm. Diabetes.
Something in the mental health space that I think is super interesting is pharmacogenomic testing, because there is a long runway when you are put on a mental health drug to know if it's actually going to work in your body or not. A test for $300 to $400 can tell you this drug will work and this drug will never work. Is it worth it to an employer group to think differently and be like, yes, I want to offer this because that's going to increase productivity. It's going to increase quality of life for my members, and it's going to get them better sooner. Yeah. I think having those conversations are super important.
Wow. Yeah, that's a different angle. Candidly, I wasn't familiar with it. What was that called again?
It's called pharmacogenomic testing.
Were you familiar with that?
Yeah. Yeah.
It's just a cheek swab.
On you.
Yeah.
It's a cheek swab.
Justin and I have talked about that, and there's more and more companies that are doing it.
And there's a lot
which makes sense because it's like you got some of these patients that are taking these drugs that aren't even.
No.
Well, they have to take them for about 60 to 90 days to see if they work. Yeah. And if they don't work.
So you might be paying a high dollar amount for the drugs and they're not even effective.
And then you have to start over essentially and start with something new. Meanwhile, you've missed work. Your quality of life is not that great.
You're
and mental health
money
is.
For it.
It's a perfect example of how the industry has been a barrier for the truth and for, lack of empirical data, desire to see if that drug is going to be effective for somebody. And that's a biggie for sure. I think it's also important when you talk about strategic partnerships. We obviously feature direct primary care. It's really a hot topic. It's really growing, is the integration of the pharmacy benefit manager with our DPCs and of creating those partnerships.
Absolutely.
And also having the DPC with the friends of the program could be for imaging or for surgical bundles and things out there. So it's a really evolving market. I think I just want to make sure I brought that up.
I actually am a patient who actually gets to have access to direct primary care, and truly it's been a game changer for our family. I mean, it's amazing healthcare. It's different than if you go to just a family practice doctor.
But the DPC also connects with the PBM for on behalf of the patients.
Correct.
Beyond you, but it's just that's another game changer there.
Absolutely.
Yeah.
All right, we can wrap it there. Thanks for joining us, Amy.
Thank you so much for having me.
Yeah,
I appreciate it.
It really has.
It has been a great day. Thank you.
All the success.
Thank you. You as well.